Yeah, we are live now.
So it's 9 a.m. and it's time for the fourth session of Pediatric Dermatology module. I welcome our President IIP Delhi, Dr. Alok Bhandari sir, and my coordinator, Dr. Vipul Jain, and today's speaker, Dr. Shilpa Garg. She is a consultant dermatologist at Gangaram Hospital, New Delhi. Initially, she was assistant professor of dermatology at Army College of Medical Sciences in Delhi. And she has even written books and has been author of many articles, and will be assisted by Dr. Vidya Yadav. She is senior resident at Lady Harding Medical College in Dermatology Department. I request Dr. Bhandari sir to please say a few words and then we start.
Well, good morning and welcome, friends. I think uh, this is purely an academic exercise, so let's go ahead with the academics right at the moment. And if you have any feedbacks, any suggestions for further adding to the modules or any new module to be taken up by Delhi IAP, please feel free to communicate. We are starting with the diabetes module also today. And all of you, I think, must have received information about that. Please register for that also. I can promise you it will give you a very great insight into different aspects of type 1 diabetes management and all aspects. And let's go ahead. Happy learning, please.
Thank you, sir. I request Dr. Shilpa Garg, ma'am, to please start the presentation.
Very good morning to all of you. So I shall be speaking on how you can treat your patients with acne. Next slide, sir. So this slide basically shows the incidence of acne across various age groups in children. So we see that it is the adolescent age group, that is in children greater than 13 years of age, in which acne is most commonly seen. That is up to 91% of cases of acne happen in this age group. And rest, you can see acne across all the age group, but it is really the mid-childhood age group, that is children between 1 to 7 years of age, though acne is rarely seen in this age group. But if you see it in this age group, it is a cause of alarm. Why so? Next slide, sir. So in an infant up to 6 to 12 months of age, the infantile adrenal glands secrete DHEA and DHEAS. And these hormones then stimulate the sebaceous glands, which is the oil glands, and can lead to acne. Additionally, in boys up to from 6 months to 12 months of age, they can secrete luteinizing hormone, which in turn can stimulate the testicular production of testosterone. And the hormone again can act on the sebaceous gland to cause acne. Next slide, sir. Sir, next slide. Sir, next slide. Yeah. So it is around 1 year of age that these hormone secretions cease, and they remain so up to 7 years of age, which is the normal onset of adrenarche. And after that, production of DHEAS levels again increase, and they can again stimulate the sebaceous glands to cause acne production. So up to 1 year of age and from 7 years of age onwards, hormones can be physiologically active and can lead to acne. So it is around between 1 year of age and 7 years of age, that is the mid-childhood age group, that hormone activity is nil. And physiologically, we should not be seeing any acne. Next slide, sir. So when you see acne between 1 to 7 years of age, you know that you have to investigate for an underlying cause, which could be true precocious puberty, Cushing syndrome, late onset congenital adrenal hyperplasia, adrenal and gonadal virilizing tumors. So in this case, we send the patient across to a pediatric endocrinologist so that they can be evaluated for all these underlying possible causes, including bone age, including serological workup, and clinical examination to look for signs, development of secondary sexual characters. Next slide, sir. So now coming to what causes acne, it is important to know what is the pathophysiology, because pathophysiology corresponds to clinical features, and then we choose the kind of treatment we want to give accordingly. So acne, we know, is a multifactorial disease. Some amount of genetic predisposition and environmental factors both lead to acne. So they are by and large 4 pathophysiological factors that cause acne to happen. Next slide, sir. So this is the diagram which shows the pilosebaceous unit, that is the hair follicle. It's coming out of the skin and its attachment with the sebaceous gland, which is called as the oil gland of the skin. So the first thing that goes, previous slide only, sir, the diagram. Thank you. So the first thing that goes abnormal in a patient of acne is that the duct gets blocked. Why the duct gets blocked? It gets blocked because there is abnormal follicular differentiation. The cells, the epidermal cells, how they differentiate is not normal in these patients. And there is increased cornification. The uppermost layer of the epidermis, that is the stratum corneum, forms a thick plaque. It does not exfoliate. It remains blocked, and so it leads to blocking of the hair follicle. So on the top where there is a circle, you see that there is occlusion of the pilosebaceous duct. So there is a keratin plaque which has now sealed the opening of this follicle. Second pathophysiological factor is that these children, the oil secretion is abnormal in its quantity and even in its composition. So their sebaceous gland secrete excess sebum, and the proportion of fatty acids in the sebum is also not normal. So both in quantity and composition, the oil production gets abnormal. The third factor that sets in is the bacterial colonization by Propionobacterium acne. So the bacterial infection sets in, and once the bacterial infection sets in, it brings with it the inflammation. So there is interleukin which are released and neutrophils are attracted, and a full inflammatory cascade follows. So these are these 4 pathophysiological factors which causes acne. Next slide, sir. So what do these 4 factors finally portray on the skin? So what we see in a patient in acne are basically 3 kind of skin lesions. First is the non-inflammatory skin lesion. That is when you see really no red colored pus-filled lesions in a patient with acne. So non-inflammatory skin lesions are basically when you see your whiteheads and blackheads. So they are skin colored lesions with no redness in it. These are basically the kind of non-inflammatory lesions that we see. The inflammatory lesions that we see in acne is when the redness comes in, inflammation comes in. So papules, erythematous papules, pustules, and nodules. And once the acne subsides, it leaves behind post-inflammatory lesion. That is the scars that we see in acne, the depressed scars, and even the hypertrophic scars. The redness that remains in the skin once the acne has resolved, and the little black lesions once the lesion heals. Some of them tends to leave behind hyperpigmentation. So that is the telltale signs of acne which are left behind on the face. So how do we grade acne? Broadly, grade 1, 2, 3, 4. Why do we grade acne? Because once we are giving treatment, we want to know that after the treatment, is the child improving? Is the acne coming down in its grade? We also grade acne to identify the kind of lesions we are seeing, and accordingly, the treatment plan changes. So grade 1 acne is basically comedones, that is the non-inflammatory lesion. So you see in this slide, mostly what you are seeing is blackheads and whiteheads. So they are skin colored, and you may see occasional papules. So few red raised lesions will also be seen. So very important to identify grade 1 acne, because treatment of grade 1 acne is totally different from rest of the grades. Why so? Next slide, sir. So it is said that the comedones, that is the non-inflammatory lesions, are mostly caused by so abnormal oil secretion comes across all stages of acne. But in grade 1 acne, the blocked skin pores is basically caused by the occlusion of the pilosebaceous duct. So the opening of the follicle is blocked. There is abnormal oil secretion. This leads to formation of comedones. However, the bacterial infection and following severe inflammation is not seen in comedomal acne. So this is important to know, because if you are treating your comedomal acne, that means your treatment is focused only on opening this blocked pore, and you are not giving any antibiotics for this stage of acne, because the bacterial infection and the resultant inflammation has really not set in. So only keratolytic agents is enough to treat your acne, because most of us normally end up giving topical antibiotics to all our patients of acne. This is a different scenario. So please look into it. If you are largely seeing only blackhead and whitehead, at this stage, you are not going to add any topical antibiotic, as it has no role, only keratolytic agents. Next slide, sir. So this is your non-inflammatory acne, the comedomal acne. After this, all stages of acne show inflammatory lesions. So how does inflammation sets in? So the plug is formed and it has blocked the opening of the follicle. The abnormal oil secretion is happening, and from this stage onwards, there is overgrowth of the bacteria, Propionibacterium acne. Once this bacteria comes, it brings in with it secretion of inflammatory mediators. So interleukin 8 and other inflammatory mediators are secreted. Once these interleukins are secreted, neutrophils come into the picture. And these neutrophils result in inflammation, leading to redness in the lesion. So the redness in the lesion starts now, and the redness can manifest in degree of severeness. So least severe is a papule. That means when you see a red lesion without any pus, then when the inflammation increases, it goes on to become a pustule, and then it goes on to become a nodule. So what happens is that inflammation sets in and the follicle is blocked. So secretions cannot come out. And so the follicle distends, the balloon distends from inside the skin. And once it distends, the contents rupture and leak into the dermis. And therefore, these inflammatory papules, pustules, and nodules are formed. Next slide, sir. So now you see the redness in the lesion has come. So once you see the redness, know that you have to introduce topical antibiotics and anti-inflammatory from here on. So grade 2 is basically your early stage of inflammation, that is mostly papules. And comedones are, of course, the start point of acne. So comedones you will see across all stages of acne, most probably. And then inflammation is not too much, so you will see few pustules. So grade 2 will be mostly papules. Next slide, sir. Grade 3 will be pustules. The inflammation is increasing in intensity, mostly pustules. Next slide, sir. And grade 4 is mainly nodular cystic acne. So inflammation is at its peak. So this is grade 1, 2, 3, 4 of acne. So next slide. So we'll come back to this again. So we know that in grade 1 acne, we are basically seeing the blocked duct along with the oil. And so the resultant clinical picture is blackhead and whitehead. And since there is no real bacterial infection, we only treat with keratolytic agents. That is any agent which is going to open this blocked pore. And we don't need topical or oral antibiotics in this acne. So grade 1 is this. And rest, grade 2, 3, and 4, we know all pathophysiological processes. That is the blocked duct, the oil secretion, Propionobacterium acne, and the resultant inflammation has set in different grades of severity. And so along with your keratolytics, you also have to add antibiotics or isotretinoin depending on the inflammation. Next slide, sir. So we'll come to now how we treat the acne in our children. So first we'll start with the routine skincare. We begin with cleansing. So how often do you clean? What do you use for cleaning? Mostly skin of children is oily. Teenage skin is a oily skin. Very rarely we come across dry skin type. Mostly in especially atopic children, we will see that they have dry skin. Otherwise, it's uh, towards oily skin. So cleansing routine is basically dependent on the kind of skin the child has. If the child has very oily skin, it is advised to wash your skin 2 to 3 times a day and avoid using any kind of scrubs or exfoliants or loofahs, because if you have inflammation on the skin and if you are rubbing and really causing a lot of friction on the skin, it can increase the inflammation. So tell your patients to don't scrub or use special rough agents on their skin. What are the kind of cleansers that you use for their skin, since the skin is mostly oily? So we use benzoyl peroxide. So benzoyl peroxide cleansers, salicylic acid cleansers, and glycolic acid cleansers. Combination of one or two together are mostly used. So I have no conflict of interest. So I will just give few of the trade names that we use, because skin is actually basically picking the right product. So if the child has oily skin, you can use face wash. It comes by the name of Reguglow face wash, Yappy Glow face wash, Vega wash. So these are good cleansers for a child with oily skin. And if you have child with dry skin, then you can go for Cetaphil gentle skin cleansers. So next step is, do we moisturize? So normally if the child washes the face and the oil secretion moisturizes the face naturally, it is not necessary to moisturize. No product is necessary for maintaining the skin. But moisturizers, even in oily skin, may be indicated, because the products that we give for acne to settle down, basically your keratolytic agents, the tretin cream and or the adapalene or benzoyl peroxide that is used for settling the acne, since they cause excessive desquamation of skin, it can lead to dryness and irritation of skin. So to combat that irritation, you may need moisturizer. So since the skin is towards the oily skin type, so we have moisturizers for dry skin also and for oily skin also. And moisturizers may have a role, especially during winter season, because the oil secretion is not sufficient to moisturize the skin in winters. So if you are looking for a moisturizer for oily skin, good brands to consider would be Aquasoft FC cream or Hydranet cream. These are usually the ones I prescribe, and they are really 200, 300 types that are available. And if you are looking to moisturize a dry skin, then I usually use a moisturizer comes by the name of Max Rich U Cream. How often do you moisturize? Depending on if your skin needs that much oil or not. 1 to 2 times a day, but mostly at night, since we give tretinoin, that is the time we must moisturize before applying your tretinoin gel. In the morning, it's optional. Next, the role of sunscreen. Absolutely not necessary for our skin type. We are not cancer forming skin mostly. So, how do sunscreens play a role in a patient of acne? So, the topical retinoids can cause photosensitivity, and even your tetracycline antibiotic, doxycycline, can cause photosensitivity. So, if when the patient comes, you tell them that you are giving this cream and this antibiotic, and in case they feel, because they have potential to cause photosensitivity, if they feel that it is causing irritation of skin once they are out in the sun, in that case sunscreen is a must. Otherwise it's not necessary. So any product that you choose, a moisturizer or sunscreen, so it is written non-comedogenic on the product. So choose non-comedogenic products so that it does not add to causing acne in the patient. Also, once the patient comes with acne, find out if they are using, if they have started using any new product like vitamin C serum. Sometimes vitamin C serum are known to cause acne. So makeup, I think teenagers, not very important, but if they insist on doing it, they can choose mineral based makeup. So every company has mineral based makeup, which basically uses this silica and zinc oxide. And these are less comedogenic. They are less likely to cause acne. Also, if they want to use foundation, then loose powder is better than pressed powder. And baseline rule for skin is that anything that you use and you feel it is making matters worse, just discontinue. And next in skincare is that you have to tell the child that there is, in some children specifically, there is a urge to squeeze and pick at the lesions. This they have to avoid, because picking at the lesions can increase their chances of scarring and can increase their chances of pigmentation also, and it can turn in more inflammation, causing more damage. Next slide, sir, please. So when they come to you, they are, everyone feels acne will settle down. Those things have changed now. Acne is now not a acute illness like it used to be, that it would come for a few months and settle down and then you are through with it. Now acne is classified as a chronic disease. In most children, it may go on for 10, 15 years also. So when you start treating your acne, you have to tell the child that we will introduce many components, oral antibiotic or topical antibiotic, plus keratolytic. And as the response sets in, products will be withdrawn. However, keratolytic agents, that is the topical tretinoin, will continue for a very long time, because the disease will continue for a very long time. Once we've controlled the active inflammation, we still need to give the child something so that the disease is not able to rebound back to its original state. So, stress on the chronic nature of the disease so that the child knows that he or she will not be applying so many products, and finally the regimen will become easy, but they still have to continue the topical keratolytics for a very long time, and that they have to learn to incorporate in their routine. Next slide, sir. Sir, next slide, please. Ajay, sir, next slide, please. Am I audible? Hello? Hello? Am I audible? I can't see the screen. Hello? Sir, can you hear me? Hello? Dr. Ajay? Hello?
Hello, we can hear you, but your slide is not moving. Hello?
I can't even see it on the screen, sir.
Yeah. But maybe I can call Ajay. Who is moving the slide?
So I think Dr. Ajay was.
Okay, just I'm calling him.
Sure, sir.
Actually, I'm just joining back.
Should I?
Can you see the screen now?
Sir, I can.
Just uploading the screen. Is the screen visible now?
It's visible, sir. We were on slide 18, diet and acne. Slide number 18, sir. Next one. Right here. Thank you, sir. Am I audible, sir?
Yes, ma'am. Please go ahead.
Sure.
Yes, ma'am. Please go on.
Thank you, sir. So next is role of diet and acne. So this area is still controversial. We have studies pro it, and we have studies showing that nothing really matters in what you eat. So there is some evidence for consumption of high glycemic diet and milk, and there is a concern about androgen abuse, especially in children who are going to gym and consuming androgen containing drugs and products. However, the baseline advice is that a relationship of diet and acne practically on skin is very immediate. You consume something, and in next 2 days, it will really reflect on your skin. So when you are giving when I give advice of diet and acne, I tell my patients, if you eat anything and it literally shows on your skin, avoid it. Otherwise, there is no need to really dig every day into food to see if this is causing acne or that is causing acne. It uh, it shows itself off well. So you really don't have to investigate. If there is something, it will bring itself out. So baseline advise it, avoid the food which they feel causes exacerbation of acne. Next slide, sir. So now we are coming on to the basic drug treatment of our acne. So when you are done with your general advice, and if you are seeing a patient who has grade 1 acne, that is your comedomal acne, so you know for this acne, what you have to use is basically your keratolytic agents. That is, your effort is only to open this blocked plug. So what are the different keratolytic agents which are available with us? It is topical retinoids, benzoyl peroxide, and azelaic acid. These are basically three products which have keratolytic activity. And the strength of keratolytic activity of topical retinoids is greater than benzoyl peroxide, which is greater than azelaic acid. So the best product to choose for your patient would be topical retinoids. Next slide, sir. So, what are the types of topical retinoids that are available? It comes by the name of tretin cream, that is tretinoin. You have adapalene, you have isotretinoin, and then you have tazarotene. So these four kind of topical retinoids are available. And the most commonly used ones are basically your tretin cream and adapalene. So how does tretinoin products act? What do they do is they normalize the follicular hyperkeratinization. So the cells which are growing in disorderly fashion to form that plug, that process of disorderly growth of cells, this product normalizes. And it has comedolytic activity also. So the plug that is formed and it is not exfoliating, this cream will exfoliate the product. So it will do two things. It will open the blocked pore and it will prevent the blocked pore from happening. So this is very important because when we treat acne, tretin is given to open the blocked pore. And once the acne lesions have resolved, but you know that abnormal proliferation of cell is the first step leading to acne. So this abnormal proliferation of cell does not happen. So as a maintenance therapy, tretinoin is continued for many, many years. So this is the only cream that does not stop for years, whether you are seeing clinical lesions or not, because this acts like a maintenance therapy. So amongst your retinoid products, between your tretin gel and adapalene, to say which is better, there are conflicting results in efficacy in the studies. But practically speaking, tretin gel has a superior action as compared to adapalene. However, because it causes strong keratolysis of the skin, strong shedding of the skin, its potential to cause greater irritation is also there. So tolerability wise, adapalene is greater than tretinoin. So if you have to choose work wise, result wise, tretinoin is better, but uh, tolerability wise, adapalene is better. So we prefer using tretinoin and we kind of give instructions and give moisturizer so that we are able to use tretinoin over adapalene gel. That is my personal preference. Otherwise, if you feel irritation is too much and you are unable to use tretinoin, you can use adapalene. Another thing in acne is that we know that acne can come in any part of the face. So when you are giving treatment, treatment is not only localized to the area which has pimple, because that area has pimple today. The other areas are likely to get pimple tomorrow, as follicular uh, proliferation in those areas may not be normal. So all products that we use for acne, retinoid cream specifically, the instruction is to apply all over the face, but avoid sensitive areas of face. So don't bring it very close to your eyelids, nose and mouth, but apply it on rest of the areas. So what is the problem with Tretin gel? You will see your patients coming back with this kind of skin. You will receive messages that skin is getting red, it is becoming very irritable, it is all flaky, it is burning, I can't apply anything else. So this is once you know that the redness, irritation and inflammation. So next slide, please. Sorry. So this slide shows the redness, the flaking, the irritation that sets in with these retinoid products. Next slide, sir. So to tackle these issues of burning, stinging, scaling, and dryness, that can be seen with all keratolytics, basically, your retinoids, your benzoyl peroxide. What do we do? So instruction is that you first wash your face at night. So because they can cause photosensitivity, retinoid products and keratolytic agents are mostly given at night. So the child washes their face, then immediately they will apply good amount of moisturizer on their face. And after that, on top of a moisturizer, you apply your keratolytic agent, that is your Tretin cream. So how do you begin using your Tretin cream? Always choose a lower concentration of product to begin with. So Tretin cream comes in the concentration of 0.025% and 0.05%. Start with 0.025% and tell the child to apply in very less quantity. How much? You tell them of size of pea. मटर भर दाना बराबर उंगली में लेना है और उतना ही फुल फेस में इसको डिस्ट्रीब्यूट करके लगा देना है. Just about enough. वो it need not be used in large quantity that you are literally massaging it in. You tell the child, you should just think ये लगा भी कि नहीं लगा, इतना कम लगना चाहिए कि you should feel कि I think this was inappropriate in quantity. So size of pea. And if you feel that the child has, there are chances the skin is not of a very appropriate quality, or if you want that the product should not cause irritation initially, you can start use on alternate night, 3 nights a week. And as and how the skin settles down with tretinoin, you can make it every night also. So these are few tips how you start using your Tretin cream. And if you feel that it still causes irritation in spite of moisturizer, in spite of the right quantity and avoiding sensitive areas of face, then you move to, so once the irritation has set in, stop all keratolytic agents for 15-20 days. Use moisturizers on a daily basis. And if you feel the irritation is too much, you can add a topical steroid cream, mid potency like Momate, for 2 or 3 days, which will settle off the irritation. Then stop your steroid cream, continue with your moisturizer. And after 15-20 days, you can introduce the retinoid again, either of a lower strength on 2 to 3 nights per week basis, or from Tretin cream, you can come to adapalene also. That's how I choose it. But a lot of people prefer adapalene from the day one. But I feel Tretin cream has superior action. So I prefer using Tretin cream. Next slide, sir. So role of benzoyl peroxide, it's a wonderful product. Unlike antibiotic creams, this product has antimicrobial action, and it does not have the risk of causing bacterial resistance. And it is also a lovely keratolytic agent, but I hardly tend to use it because I am more for retinoids than benzoyl peroxide. And next slide, sir. Azelaic acid, I have never used this product, but the advantages of this product is that again, it is a keratolytic agent. Also, the irritation potential with this product is minimum, less as compared to benzoyl peroxide and tretinoin cream. So if you have a patient with atopic dermatitis and you know they are sensitive skin children and you want to add a acne agent, keratolike agent, I think that is a time when this product finds its place really in my regime. And another advantage of using this product is it also has a role in reducing the post-inflammatory hyperpigmentation. So the dark marks that you see, these can be helped using azelaic acid. So now we are done with discussing our treatment of grade 1 acne. So to sum it up, your prescription of grade 1 acne would be face wash in the morning and moisturizer in the morning if you need it. And on top of that, sunscreen if you have a photosensitive skin. And at night, it will be face wash, then a moisturizer. And 1 minute after applying a moisturizer, on top of that would be your tretinoin cream, 0.025% in very little quantity all over your face. And next slide, sir. Now we come to treatment of inflammatory grades of acne. That is from grade 2 onwards to grade 4. You know that bacterial infection and inflammation has set in. And now your role for topical antibiotics, oral antibiotics, and systemic retinoids, that is your isotretinoin, begins. So if you have grade 2 acne and you see you have just, so how to choose between topical antibiotic or oral antibiotic? It is simple. If you have less number of lesions, you go with topical therapy. If you have large number of lesions, you know you have to switch to oral therapy. So treatment of mild cases of grade 2 acne would be topical antibiotic because inflammation has set in, and that will target your bacteria and inflammation, these two pathogenetic factors. And you add your topical retinoid because you need to open the blocked pore. Next slide, sir. And when the inflammatory cells are more in number, and you know there are many pustules also, then you can replace your topical antibiotic with oral antibiotic, which will again target your bacteria and inflammation, and you add a topical retinoid with it for its keratolytic activity. Next slide, sir. So what are the topical antibiotics that you have? We use clindamycin, erythromycin, dapsone, and nadiflox. I've never used dapsone, so I'm not going to touch on it because I have no personal experience really with it. I'd used it in my initial days and never really found it very good. So I'm not a very, it's not one of my go-to products. So, and the oral antibiotics that we have are basically broadly two categories: tetracycline antibiotics, doxycycline, limicycline, and minocycline, and your macrolides, azithromycin and erythromycin. Now, in your topical antibiotics, personally speaking, I feel nadiflox works better than clindamycin, and that works better than erythromycin. So my go-to antibiotic is nadiflox as far as topical antibiotic are concerned. And oral antibiotic, tetracyclines are preferred over macrolides. Macrolides are second line because macrolides, we believe, azithromycin finds its place in treating certain other important infections in the body, your lung infections. And so we don't want to overuse and abuse this oral antibiotic because it can lead to drug resistance. And tetracyclines are superb in its action. And so tetracycline antibiotic is preferred over macrolide. Next slide, sir. So amongst these tetracycline antibiotic, you have doxycycline, limicycline, and minocycline. We start with doxycycline. Then we go, if it is not very effective, we can try limicycline. Minocycline, efficacy-wise, is supposed to be most superior. However, I never use it because amongst the three, this is the only oral antibiotic that can cause very severe side effects. It can cause lupus-like syndrome. It can cause autoimmune hepatitis. It can cause drug hypersensitivity syndrome. And it can even cause bluish black pigmentation on acne scars and on your shin, which is quite irreversible. So even with its efficacy, the side effects are so horrible that you can't justify choosing minocycline when doxycycline and limicycline can do the job. Between doxycycline and limicycline, doxycycline is cheaper, limicycline is more expensive. How limicycline finds its place, I will tell you, is that it has a faster onset of action. So if the child is looking at a close event, some wedding or some function, and has sudden acne, start with limicycline. The final result after 40 days with both doxycycline and limicycline, practically speaking, will be the same. The end point of action, practically speaking, does not matter, but the start of action, in my personal experience, I'm adding, is better with limicycline. So I always start with doxycycline, and unless and until the child has a real function to attend, because it's reasonably priced, we have our longest experience with this drug. And so that is my preferred oral antibiotic to go to. Next slide, sir. So, because we know that we can't give tetracyclines to a child who's less than 8 years of age because of the problems related to their dentition. So, if you want to give an oral antibiotic in a less than 8-year-old, give azithromycin or erythromycin. And in case the child can't tolerate or you can't give these two, then you give trimethoprim. Next slide, sir. However, in a small child, we really avoid using oral antibiotics. So it is hardly given, but in case you have to, then that's what you do. And now we know that this is grade 3 acne. If it is towards mild to moderate, oral antibiotics and topical retinoids work well. Next slide, sir. And once you have your severe grade 3 acne or grade 4 acne, that's when your oral isotretinoin play role starts. Next slide, sir. So oral next slide, sir. Thank you. This one only. So oral isotretinoin comes with its baggage of some serious instructions, blood monitoring, and side effects, which can be seen, and you have to tell the patient. One of the concerns that sometimes I find in giving the drug is that it can cause premature closure of growth plates. So, however, it is reported that this is only typically seen when you give very high doses for a very long duration of time. But this thing still stops me from giving this drug until the child has reached its full height. So this is one of the aspects with oral isotretinoin. Next slide, sir. So how do we use our topical and oral antibiotic in a way that it does not lead to drug resistance? So the thing is that avoid monotherapy. Don't give clindamycin or nadibac gel just standalone. We know that the first step of acne is using a keratolytic agent, and antibiotic creams standalone have no role. So any which ways, pathophysiologically also it doesn't make for sense, and it can lead to antibiotic resistance. So when you are giving a topical or oral antibiotic, always combine it with a benzoyl peroxide or a retinoid, which will prevent antibiotic resistance from happening. Second important point is, when you are giving oral antibiotic, ideally don't give any topical antibiotic. Then you just combine a oral antibiotic with a topical retinoid. And because of this drug resistance and to ease the application, now we have fixed combination therapy also. So your topical antibiotic is combined with a retinoid to prevent basically this problem of antibiotic resistance. So how long do we use these oral antibiotics? So earlier on, we would give it for many years, but now we know that we keep it short to not more than 3 months. So how I treat is that once we give antibiotic, we know normally 30 to 40-day antibiotic is oral antibiotic is broadly required in all the patients, practically speaking. So that's when we plan our second review after 30 to 40 days. And that's the time when most of the lesions have started responding. And we try to stop oral antibiotics, withdraw them at that time. But if you have to give it for up to 3 months, the guidelines say that it can be safely used. So next is that don't switch antibiotics. So if you've given doxycycline and results have come and patient comes back after few months and few years, and when you know that the inflammation has increased again and you need to introduce oral or topical antibiotic again, don't give doxy once and then lamicycline second and minocycline. Go back to the antibiotic that you have used. Next slide, sir. So this is your grade 4 acne, which demands treatment with oral isotretinoin. So now I will sum up how the prescription of grade 2 acne looks like. We can keep it to this slide, sir. Thank you. So, okay, I'll speak on maintenance therapy. So we know that once all the acne has resolved, then you will stop your oral antibiotic, your topical antibiotic, and the child feels he is fine, she is fine, no need to do anything else. Please stress in the first visit only that this cream at night, that is your tretin cream, will not discontinue for many years, maybe up to 1 to 5 years. Also, one important fact that I forgot to mention was practical point is that when you use tretin cream at night, it causes certain irritation in the skin. So some of the children, if they are bleaching their face, waxing their face, or threading a certain part of face, or going for any kind of chemical treatment, please write in your prescription to stop topical retinoids or your benzoyl peroxide 7 days before any procedure on their face. Because a lot of patients will bleach it, wax it, thread it, and will come back with a burn. So make sure to tell them that since this product causes irritation, they must discontinue 7 days before they get anything done on their face. And this topical tretinoin cream can be continued for next 1 or 2 years. So they will feel that they don't need it, but once they discontinue all treatment, you will see that the acne comes back again. So role of maintenance therapy in acne is very important, because we don't have to go back to giving oral antibiotics and topical antibiotics again and again. And it is a nuisance also for the child to apply so many products. So your prescription for inflammatory acne in which the lesions are less would be, you will write morning, do your face wash, apply Nadibact gel all over your face, and 1 minute on top of that, apply your moisturizer if you need it. And if you are photosensitive, then on top of moisturizer goes your sunscreen. So one on top of the other. And in the night, you do your face wash, then you first moisturize your skin, and after that you apply your tretinoin gel at night, full face in very little quantity, to be stopped 7 days before you get any procedure done on your face. So you do this and you tell your child to come back in 2 months. This will take at least, results don't come normally before 4 weeks to 6 weeks. That is the minimum time we give to see whether the treatment has shown some results or not. So there is no point reviewing a child every few days. So the first review visit with topical therapy is after 6 weeks to 8 weeks, 1.5 to 2 months. And then when you see that lesions still continue, you continue with your topical antibiotic for 2-3 months more. And once the lesions have settled down, you remove your topical antibiotic and tell the child to continue with tretin. And if you see more inflammatory lesions, then your prescription would read capsule doxycycline in the morning and face wash and moisturizer. And in night, it would be face wash, moisturizer, and tretin gel. And then you ask the child to review after 20 to 40 days. For me, it is normally 30 to 40 days. And once we see that the inflammation has settled down reasonably, then you can stop doxycycline and introduce topical antibiotic cream in the morning. And then once the inflammation settles down totally, you can stop topical antibiotic and your tretin gel continues to go. Last slide, sir. So take home message, because for you at your end would be, don't use antibiotics if you are just seeing comedones, and don't overuse antibiotics for a very long time. Limit their use to 3 months. Make the parent and child understand the concept of maintenance therapy, that is tretinoin cream to be applied for many years. And last slide, sir. Next slide, sir. Yeah, thank you. With that, I end my presentation.
Thank you, ma'am, for a wonderful presentation and excellent discussion. House is open for the questions. Dr. Vidya, do we have any questions? And any panelists want to ask anything?
Yes, sir. Most of the questions are regarding the brand names, which are already answered. But some people are asking the treatment of neonatal acne, and is teratogenic? Yeah, tretinoin is teratogenic. So, what is the safety age group for using retinoids?
Sure. In all the other cases, age group of acne, neonatal, infantile, if it is not too much, because the skin is very sensitive, wait and watch. Things mostly clear by itself. Also, we know that it is because of a certain physiological hormone. I think it is not necessary to treat. If you must, use benzoyl peroxide or adapalene gel after sufficiently moisturizing the skin. And as far as teratogenic, so sir, in normal teenage girls, we do tell the parents tretinoin gel has to be stopped 3 months before you plan pregnancy. And oral isotretinoin has to be stopped, and a wash up period of between 3 to 6 months. So we advise up to 6 months has to be given before any pregnancy is planned. So in all other acne, you can give topical antibiotic and tretinoin gel or benzoyl peroxide. But sometimes wait and watch. It is not a compulsion to treat. Sometimes it clears off
Sometimes
by.
masterly inactivity is the most appropriate treatment.
Sorry, sir.
Because these masterly inactivity, because these are most
Absolutely,
likely
sir.
self-limiting
Absolutely.
lesions.
Just your what you see, you have to immediately treat, not necessary.
Dr. Vidya, next questions? Any more?
Yes, sir. One more question is treatment of PCOS related acne or hormonal acne.
Sure. So, very tricky, I would say. So, so if you know that we know, say, ki menstrual activity also takes 4 to 5 years to practically settle down in the body. So, when you have your teen and it is giving you clues that the acne is hormonal in nature. What are those clues? You know that there is a premenstrual flare. The acne kind of increases just before your periods. You have signs of hirsutism. Child is giving you history of irregular periods. And you know that you are largely looking at a hormonal component. I would suggest uh, normal lifestyle instructions are a must. Lose weight, be metabolically, physically more active, go for your walks. If the child is on the thinner side, you have to explain to the patient that it'll automatically solve many problems because drugs will only also fix till the time they are given. Number one. Number two, I still go by, so I will tell the child lose weight and I will still go by treating their acne in a way I would treat a non-hormonal acne. That means I will give a shot of doxycycline and your topical retinoids and see the child after 40 days because majority of the hormonal acne also responds well to just the standard treatment of a non-hormonal acne. So if you are seeing the child after 40 days and if you feel that the results are not as expected, if there is poor response, now you have two options. Then you investigate to see if the child has PCOS, which also is dicey because most of the investigations are not very accurate, which includes your ultrasound and your blood report. But however, clinically, you know that you are looking at a hormonal acne. I resist giving hormones, but if you have to, when you know that you have done chemical peels, you have given your antibiotics, and with less you are not able to control, in that case, go for hormonal therapy. So that's how I take it in a slow fashion. We add chemical peels also, it increases the response to treatment. And if all that is also not working, then we add Dine 35, so which we resist. A very strong oral therapy in the child because we know that the menstrual cycle also takes its while to settle down, and not unless the child is 17, 18 years old that we want to jump into giving Dine 35. But it depends on the case. If we have to, then you go ahead.
Sir, one last question. Role of steroids in treatment of acne.
None. For you, please remember, you don't have to use at all. For us, I'll tell you. So, like I've said, topical steroids, if you feel that you've caused irritation of the skin with retinoid, you can give just for 2 days. It will be enough. It will settle the inflammation. And then moisturizers will settle it out. Number two, where we use it once you are using oral isotretinoin. So steroids are not given in treatment of acne. In fact, steroids are a cause of acneiform eruption. You form acneiform. So in a patient who's on oral steroid or topical steroid, they will come with acne. For us, if we are giving oral isotretinoin and we know that initially the inflammation increases, so, with oral isotretinoin in a patient with severe inflammatory acne, oral steroids are given in a small dose for a short while, that is 2 weeks in and out, just to kind of overcome that inflammatory stage of acne. And in case of children who have congenital adrenal hyperplasia, that I have never treated, but that is also an indication for oral steroids then.
Ma'am, many delegates have asked for a picture of acne neonatorum. Can you share it, and I'll share it with the delegates in the group? You can send it to me, any picture of acne neonatorum. So we'll share with the delegates.
Can I share it to you later, or you want to share right now?
Yes.
I should search
No,
for it
you
right
can
now.
share me later. Later also.
Sure, sir. I will have it.
Sure.
I think, dig it out and give it to you, sir.
Sure, thank you.
Sure.
Any other questions?
No, sir. Thank you, sir.
Okay. So it had been a very informative and very crisp and lucid presentation. Thank you very much, ma'am, for such a wonderful presentation.
Thank you, sir. Thank you for having me here.
Dr. Bhandari sir is again here.
Yes, it's been a really great morning. Very much learning, and the way you have taken us through acne, I think it is well revised and a time well spent this Sunday morning. I can always say, Dr. Shilpa, thank you for that. And
thank you, sir.
And sorry for the technical glitch in between.
Not at all, sir. Not at all.
That is part of us. That is part of us. We are very much adapted to it.
Okay. So we close this session, today's session. Thank you so much, ma'am. And thank you, sir. Thank you all the delegates for joining in.
And look forward to seeing you in Tide session. Yes. Ajay.
We have shared the link for the Tide session in the group, and please join. Thank you so much.